Well, welcome everybody. This is the first webinar of the West Africa Regional PrEP Learning Network. We're really excited to be kicking off this community of practice. We will dive into about the community practice in a little bit more. I just want to introduce our panelists today. My name is Katie Schwartz. I'm with FHI 360. I'm the Deputy Director of the Choice Collaboration. We also have Nirja Bavaraju from Afton Bloom in the Choice Collaboration. She will be facilitating the discussion today. We have Definite Namo from Pangaea Zimbabwe AIDS Trust in Zimbabwe. Def, you want to say hi? Wave. And then Patricia Jaconia from LVCT Health in Kenya. And I think, Patricia, I'm not sure if you're still on video, but she will be providing experiences from PrEP rollout in Kenya, and Def will be doing the same with their experiences with rollout and scale up in Zimbabwe. Next slide. So our agenda today is to briefly introduce what Choice is, as well as our vision and goal for the Learning Network. Nirja will take us through a framework and some key topics for discussion. And then we will hear from LVCT Health and PZAT on their experiences with oral PrEP rollout in Kenya and Zimbabwe, and go through some of the key questions around their PrEP guideline development, implementation planning process, stakeholder engagement, and a number of other issues and challenges that were tackled early on in PrEP rollout. And then we'll have plenty of time for Q&A and discussion. So similar, using the chat monitor as you have questions, please feel free to do that. It is very helpful. I think the default is to write directly to the panelists, but if you use that too, and then there's a drop down to write to all panelists and attendees, it's really helpful if everyone can see what the questions are. One of the challenges with this platform is that the participants, I don't think, can see who all is on the webinar. And we are looking into other platforms to change that so people can see who else is on. Currently, we have about 70 attendees from Liberia, Nigeria, Ghana, Cameroon, Cote d'Ivoire, Mali, and the United States. So welcome everybody, and we're really excited to have everybody participating in this session. You can also raise your hand if you have a question, and that icon is at the bottom of your screen. And then we can take you off mute for the Q&A, and we can make sure people's audio is working, and we can have discussion that way. And as well, if other people want to share experiences on these topics from your countries, or country-specific questions, please feel free to ask them during the Q&A and discussion session. And then we will end with a brief wrap-up and survey. We really want to make sure that these sessions are targeted towards the priorities and the needs for PrEP rollout in your country. So we're just going to try to prioritize what the next sessions will be, and your feedback in that area will be really important. Okay, next slide, please. So a brief introduction to Choice. Choice is an 18-month collaboration funded by USAID in partnership with PEPFAR, and through two central mechanisms that you might be familiar with already: meeting targets and maintaining epidemic control, or EPIC, and reaching impact, saturation, and epidemic control, or RISE. So the goal of this collaboration is to address the technical gaps and support national scale-up of antiretroviral-based HIV prevention products in PEPFAR countries through catalytic evidence generation, translation, and research utilization. So Choice is a collaboration between EPIC and RISE. It's led by FHI 360 and JPIGO in partnership with Afton Bloom, Avenir Health, LVCT Health, and PZAT. The next slide. And so here we are with the West Africa Regional PrEP Learning Network. This is one of the initiatives of Choice. We have kind of a sister network that's more globally focused, but this is the start of a more regionally focused learning network. There's currently 125 people from 10 countries in West Africa signed up for this community of practice. It's open to anyone from national ministries, implementing partners, NGOs, CBOs, or funders throughout West Africa who are engaged in PrEP rollout. What the Learning Network is a virtual learning series that's designed to support oral PrEP rollout and scale up across West Africa. Different webinars will dive into specific topics from guideline development, implementation planning, demand creation, for example. And speakers will include experts from the field, as well as implementers from the region and countries outside of West Africa to really facilitate cross-project, cross-country experience sharing and learning. And we really want to help facilitate that exchange of ideas and best practices, as well as also highlight the tools and resources that are available for use to expedite and enhance PrEP delivery for those who need it most. These webinars will be held monthly. They're always going to be the third Wednesday of each month at this time. They will be for 90 minutes, and for now they are scheduled through May of next year. As many of you realized, I think recently there were links to sign up for the community of practice in the Learning Network. And as it currently works is you need to sign up individually for each session on a monthly basis. So all of the webinars will be posted on PrEP Watch. There's a West Africa Regional PrEP Learning Network page on PrEP Watch dedicated to this community of practice. The link is on the slide here. And you can register for the upcoming webinars on this page. And you can also see the resources from previous webinars on this page as well. So this session is being recorded and it will be available, and the slides from each session will be available on PrEP Watch as well. So in case you miss a session, you can always check in on that later. And we'd always love your feedback as well. For questions or thoughts on the network, please email westafrica@prepnetwork.org. If you have topics of interest prior to sessions, if you have specific questions from your country on the session topic that's upcoming, we'd love to have them in advance. We can integrate them into the session as much as possible. And it's just going to be really nice to hear from you over the coming months as this community of practice continues. So thank you. Next slide, please, Aubrey. And I will turn things over to Nirja to take us through these key topics.
Great, thank you, Katie, and welcome everyone. We're really looking forward to working with you over the next year or so. We wanted to provide a quick snapshot of some of the key topics that we will be covering for PrEP delivery right here at the beginning of this first webinar. This is a framework that we have developed to support PrEP introduction across different countries. And it was really built on the experiences in South Africa, Kenya, and Zimbabwe as they were rolling out PrEP initially. And we thought it would be helpful to just share here because it really is a nice framing of the topics we will be covering through this webinar series. So the first, as you can see here, is planning and budgeting. That will be our main topic for today and for the first several sessions, where we will be talking about developing guidelines, developing implementation plans for oral PrEP rollout. The framework then includes other topics, including supply chain management, PrEP delivery, and that PrEP delivery is something that we will be really focused on. We have several sessions that we will be conducting on healthcare provider training and other topics, including delivery models. Also includes uptake and effective use, and some of the topics that we can cover there include demand creation strategies and training and support for PrEP ambassadors. And then monitoring is a topic that we will cover as well, including various tools and resources that have been developed by other projects to support monitoring and evaluation for PrEP rollout. This framework we will also come back to in one of our next sessions because it serves as a useful organizing tool for a number of the tools that have been developed for PrEP rollout in other countries. So we will be coming back to this, but just wanted to note that for today, we'll really be focused on the planning portion of PrEP delivery and PrEP rollout. Next slide, please, Aubrey. So with that, we'd really love to get started and to hear from our colleagues, Patricia and Definite. We are going to get started with Patricia from LVCT Health in Kenya, and she is going to start by sharing a brief overview of how PrEP was introduced in Kenya, why it was introduced, how it started, and then also how it's scaled up in the past few years. So Patricia, can I pass that on to you?
Yeah, sure. Thank you. And yes, my name is Patricia, working with LVCT Health in Kenya. And how we, as a country, we decided to roll out PrEP in 2015. We had about more than 77,000 new infections in the country. And at that particular time, we had just done our new strategy for the country, giving directions on how to achieve the HIV prevention, but also our targets for care and treatment. So we had the strategic framework and also a prevention revolution roadmap that was very ambitious. We wanted to reduce our new infections by 75% by 2020. So PrEP came in, again, basically because we had looked at the basket of prevention tools that we had, but it always felt like there was something else that would be required based on the different vulnerabilities and dynamics that were identified. And so in 2014, when we came up with this, we had also signed the UNAIDS prevention targets that were to be realized by the year 2020. And when we looked at our data and the trends, our reductions were quite low. So that's when Kenya actually came up, when there was enough evidence that PrEP works, Kenya made a decision to take on PrEP. And also because we had a number of demonstration studies that were being done in the country. So there was actually sufficient evidence to show that adding PrEP into the bigger basket of prevention would get us to the HIV prevention targets. And if not, we'd be very close to the 75% reduction. Yeah, thanks. Over to you, Niraja.
Thanks, Patricia. I think we can keep going. So maybe Aubrey, you can go to the next slide. Go ahead, Patricia.
All right, thanks. So how did Kenya introduce PrEP? In 2015, the Kenya Pharmacy and Poisons Board approved TDF and FTC for use as oral PrEP. And in the following year, through the National AIDS and STI Control Program, a meeting was held and discussions were had at that particular moment with sufficient evidence from the demonstration studies and clinical trials that would inform the development of the national guidelines to roll out PrEP. So when the decision was made, some of the things that the country was grappling with is, who do we target with PrEP? And so as not to stigmatize PrEP, Kenya decided that PrEP was going to be available to anyone who is at substantial ongoing risk of HIV infection, as opposed to just focusing on one population. So LVCT at that particular time were doing a demonstration study, and we also had the options project. So we supported with mapping the key stakeholders in the country, who are the people who are offering HIV prevention services, were already doing some demonstration studies, were involved in the clinical trials, or had funding also to be able to support rollout of PrEP. So with this list of partners, we worked together with the National AIDS and STIs Control Program to come up with a list of who would form the PrEP Technical Working Group. So officially in October 2016, we held our first meeting that was chaired by NASCOP, and we ended up coming up with a plan of how to continue with the technical working groups, but then also how to work together to ensure successful implementation of PrEP. So at the initial stages, the TWG met very often, sometimes every 2 weeks, and then monthly, before we then came back to having quarterly meetings. And also the TWG was divided into subgroups, subcommittees. And the subcommittees included leadership and governance that was basically focused on the national government leadership and also the county level. And we had an advocacy, community engagement and communication subcommittee that would look at community engagement and how to sustain demand creation for PrEP. We also had an M&E technical working group because the tools that were going to be used throughout the implementation needed to be discussed. We had a research and costing subcommittee that continuously looked at which other questions had not been answered, either by the demos that required answering the process of implementation. We also had a commodities subcommittee that was looking at the availability of the commodities, how they would be distributed across the country. So we engaged different communities at that time. The serodiscordant couples, we had another engagement with the adolescents and young people, and also with the different subpopulations and the key populations in Kenya. So it was critical at this time for community buy-in, support, and also mobilization. So they were involved in the entire planning process. And this team worked together to develop a national scale-up plan with prioritization in terms of the target geographies and the operational mechanisms that would be implemented, and also we were able to guide the implementation of PrEP by the different stakeholders. So during that time, options had come up with different tools. We had developed a rollout scenarios. The rollout scenarios tool helped us be able to cluster the country into counties that had very high HIV infection rates, which counties had key populations. Our epidemic at that time was largely driven by new infections amongst adolescent girls and young women. So where were they? And we were able to cluster the counties into the high priority that had about 9 of those counties. And then we also conducted a situational analysis, what gaps were there within those counties that were being targeted, and also worked on a facility assessment to be able to prepare those facilities for scale-up. Next slide. How have we scaled up PrEP since 2016? So officially, PrEP scale-up was done from May 2017, targeting, first of all, the 9 counties with the highest HIV prevalence and new infections. And highest prevalence, by that time, we had up to about 27% prevalence, with very high new infections in those counties that were more generalized than specific to our population. So demand creation campaigns were conducted. And as I mentioned, we had a subcommittee that was dedicated to the demand creation. So we had a plan for how the different communications were going to come out. The initial plan had a general population view where we were flooding all media with information about PrEP, and then now went to targeted populations. We worked with the media to actually train media personalities to get the correct information about PrEP. And also, and so we were able to actually have a very successful demand creation at the beginning. Then training curriculums were developed for the providers, and a PrEP toolkit was developed. The toolkit had demand creation information, but then also adherence and how to support clients who are on PrEP. So we had training of the master trainers, first of all, that were scattered across the country in different counties. And their role was to ensure that facilities, the providers at facility level were trained, and also those who are managing community level service delivery points were equally trained. So after that is when now the tools were also developed. We had indicators, and the indicators were drawn from the demonstration studies, and all the different indicators helped us to develop the main tools that were going to be used. And we were also able to integrate PrEP into the existing national ARV commodities quantification, procurement and distribution system, which is centralized in Kenya. So it made it very easy for facilities to get their commodities. Now, since the scale up started, we have managed to scale up to 1,994 facilities in the country around all the 47 counties in Kenya. And since then, we have had at least 58,000 ever initiated on PrEP. Next. Thank you. I'll hand over back to Niraja.
Thank you, Patricia. And if anyone has questions for Patricia on what happened in Kenya, you can feel free to start adding those to the chat box. We will come back to questions for both Patricia and Definite at the end. So Def, can I pass this on to you to give us a little bit of an overview of why Zimbabwe introduced PrEP and how you actually went about initial introduction and then scale up.
Thank you so much, Niraja, and hello everyone. I'm Definite Namo. I'm with an organization called Pangaea Zimbabwe AIDS Trust, based in Harare. Just to start us off, so Zimbabwe has a high HIV prevalence of about 14.7%, and our incidence is 0.47%, and this is based on our ZIMFIA that was published in 2016. So this is pretty high. And we had not seen any significant decline in HIV incidence prior to the global guidance that was issued in September 2015. We were also missing our targets in terms of new HIV infections. For example, in 2020, our target was 22,000 new infections, and we are currently at 38,000. So you can see the disparities in us not meeting our prevention targets. So we're also going with the revitalization of prevention services, and there was strong political will during that time to make sure that the HIV incidence goes down. So coupled with that, we also have a standing adaptation committee in Zimbabwe. So the standing committee is responsible for adapting any global guidance that is issued. Next slide, please. So the composition of that adaptation committee it's highly representative, and we have Ministry of Health and Child Care and the Medicines Therapeutic Advisory Committee that chair that committee. And we have the various departments of Ministry of Health that are part of that committee. There's technical guidance from the World Health Organization, from UNICEF, and from the academic world. And there are also specialists like pediatricians, physicians, and OBGYNs that are in there. And from the donor community, we have the Center for Disease Control and USAID. And we also have community representation in that committee. So when the guidance, the global guidance came out in September 2015, we're likely to be hosting ICASA at the time. And soon after ICASA, the committee, the adaptation committee met and drafted TORs, terms of reference, for the various technical working groups that were emanating from the guidance that had been issued. And as part of those TORs, one of them was for PrEP, which is where we came in under options. And part of the mandate of this, of the TORs, were to develop policy guidance as it pertained to oral PrEP. So in terms of the TWG, we then met and we started inviting people to the TWG. And the main representation was from policymakers, from the Medicines Control Authority of Zimbabwe, researchers, advocates, civil society, and we also had adolescent girls and young women represented in that committee, in the TWG. Next slide, please. So when it came to scaling up PrEP in Zimbabwe, the way Zimbabwe is structured is in terms of health facilities, we have the central or provincial facilities. These are the main referral facilities. And then we have the lower level, which is the district level facilities. And then we have the lowest level, which is the clinic level. So in terms of scaling up of PrEP, we started with the central level. And the reason why we did that is because at the central level, these are the referral facilities, and you find a lot of specialists at that central level. And the idea was to start at that level so that if there are any complications with people being initiated on PrEP, we do have specialists that can quickly attend to those clients who are initiated on PrEP. And then from there, we then went to the district and now at clinic level. And also in terms of population, we started with female sex workers, adolescent girls, key populations, men at risk, and men at risk would include men who have sex with men, long distance truck drivers, and then we also had serodiscordant couples. But I'll talk later about how these populations were identified. And just before I hand over to Niraja, I wanted to talk about how the TWG met. So initially we were meeting bi-monthly. So we're meeting twice a month. And from there, we went on to meeting monthly. And from the TWG, we realized that there were so many areas of focus that the TWG needed to focus on, and it was difficult to discuss everything in that TWG. So what we ended up doing was to have some subcommittees that would focus specifically on specific issues. So for example, we had subcommittees like the training subcommittee, we had communications and advocacy subcommittee, the monitoring and evaluation subcommittee, and also the quantification subcommittee that would look at the supply chain issues and quantifying how much PrEP would be needed per quarter. So this is how we started. I'll stop here for now and hand back to Niraja. Thank you.
Thank you, Def. And we have a number of really good questions coming through the chat. So I will start to pose a few of them. And I know others, Katie may jump in as well with a few questions. So I think one of the first the questions that people had was, did you face any resistance to PrEP rollout? Were there any stakeholders or groups of stakeholders who were opposed to PrEP rollout, and how did you address that?
All right, thank you. So maybe if I may start. In Kenya, yes, initially we faced a lot of resistance, one from the religious leaders. But how also our work is structured, we have the National AIDS Control Council, whose main role is to ensure multi-sectoral coordination and engagement, especially when certain products are being introduced to the market. So there was the issue of religious leaders thinking that it's going to encourage promiscuity. So we had targeted forums with religious leaders, and we were able to answer all their questions. And any myths and misconceptions they had about PrEP initially. So that was like the main resistance. But we also had a bit of resistance from people living with HIV, also asking us the impact of introducing PrEP and how that would actually affect access to ARVs. So again, with that engagement, and the government was able to demonstrate that how the budgets were different, and that there was actually sufficient ARVs for all those. We have about 1.6 million at that time, that there was actually sufficient, and how PrEP was going to be supported by external donors, and how that balance would be arrived at also at country level. So people living with HIV were equally involved in the demand creation also for PrEP. Thanks.
Okay, I can add on to that. Thank you so much, Patricia. So for Zimbabwe, what happened was we had just had a demonstration project among female sex workers that had just been completed. And this demonstration project was looking at PrEP delivery among female sex workers. So one of the challenges we faced was that people thought that PrEP was for female sex workers, and there was a lot of resistance in pushing PrEP for other populations. And what then happened was then DREAMS had just started delivering PrEP among adolescent girls and young women, and they were also facing the same problem. So what happened during through the TWD was we started talking about developing a communication strategy, but we did not know how much information was out there in the communities. So what then happened again was we had a request from ministry, and through options, we then conducted community dialogues nationwide. And these community dialogues were meant to understand from the community perspective and end user perspective what it is that they knew about PrEP, what were the myths and misconceptions that were in the community around PrEP. And with that information, we then, it then helped us develop a communication strategy to address all the myths and misconceptions that were there in the communities, what people thought PrEP was, and developing key messages so that people understand what PrEP was. So that was the process that we went through. But part of is also having the right people within the TWG that will then go and disseminate information in the communities. So we did have civil society representation within our TWG, and they were taking information and cascading it in their communities where they were working in. We also had USAID as part of our TWG, and we're helping each other in terms of strategies. What is it that we can do to make sure people understand what PrEP is and demystify the myths and misconceptions that are in the communities? So thank you.
Thank you both. There were also a series of questions about making PrEP available to a broad range of people, including adolescent girls and young women and the general population. Could you both speak to how those decisions were made, and if concerns about stigma played a role in those decisions?
So in Kenya, I think because our initial approach did not focus on just one population, but rather, it was very general, that for anybody who feels they're at ongoing risk, then PrEP was available. So we were able to break the stigma right at that level and make people not see that PrEP is just for key populations or for people who are promiscuous, as they were discussing it before. And so that helped us to address the issue of stigma. And also for the adolescents and young people, we wrote on our guidelines, the HIV testing guidelines that allows a 15-year-old to take up the HIV test without consent. And so it was quite easy to write on that and say, if a 15-year-old can actually take up testing, then it means the person, that young person understands their level of risk, and they can also be able to make certain decisions around accessing and utilizing PrEP. So that for us became quite useful. and ended up even at a point where now the country was able to develop certain guidelines like young key population guidelines that also recognize we have young key populations from the ages of 15 to 19, which was a problem before. But now with the evidence of seeing more young people coming up for PrEP, that really helped us be able to talk to different stakeholders and make them understand the levels of risk. And also the data in the country at that time showed that more than 50%, actually we had 51% of all the new HIV infections came from young people aged 15 to 24. So we used that evidence to convince stakeholders who had reservations. Thanks.
Okay, so for Zimbabwe, the process of identifying which populations and which geographic area to start with was also a very complex one. And we did not have all the resources needed to roll out PrEP to anyone who needed PrEP. So what happened was we had just conducted the hotspot mapping exercise. I'm sure it happened in several countries, and this was supported by UNAIDS. So that hotspotting exercise helped us identify the various geographic areas with the highest HIV prevalence. And we also had from our Zimfia data, from our DHS data, we also had the demographic health survey. We also knew the various prevalence by population. So what we then did was, through options, we embarked on an exercise where we created rollout scenarios. So we had various scenarios, and the rollout scenarios were an attempt to try and strike a balance between the geographic areas with high prevalence and also the population groups with high HIV prevalence. So we came out with various scenarios that we presented to our technical working group. And there was a lot of discussion around that. But what we then ended up doing, we sort of looked at how to strike the balance and where would get the most benefit from delivering PrEP. And we ended up selecting the female sex workers, the men at risk, adolescent girls and young women, and serodiscordant couples as a phased approach. So we started with those priority populations based on our national epidemic. And then later on, we then said, because now we have more resources, we are then able to deliver PrEP to anyone who thinks, who feel they're at risk, and also based on our risk assessment. So we developed a risk assessment tool through the technical working group, and also from assistance from the clinical trials, the researchers that had conducted the clinical trials, and from the researchers that had conducted the demonstration project. And we came up with the risk assessment tool that the risk screening tool that we're using to assess whether someone was eligible for PrEP or not. And the risk assessment tool is pretty simple. It was looking at unprotected sex, whether someone had been exposed to, had STIs before, and they'd
Oh, I think we might have lost Jeff for a moment. Can everyone else hear me? Okay.
Yes.
Okay, well, why don't we go on while we're waiting for Jeff to come back. One of there were several questions that people had on what we know about the effectiveness of PrEP in actually reducing new infections and HIV incidence so far from the rollout in Kenya. And then also a question about whether there's been an experience with increasing drug resistance, or what we know about drug resistance from the initial rollout. So Patricia, perhaps you could speak to that for Kenya.
Okay. So maybe if I can start with the drug resistance one, we also had an in-country study on drug resistance. So for any person who's seroconverted while on PrEP, we have a clear protocol of what needs to be done before they are started on ARVs. So it includes them going through the resistance tests. And what we actually realized is a number of them had actually seroconverted even before they started PrEP, but they were probably at the window period. Because for us, you're tested, if you're eligible to be given PrEP, you're started on PrEP immediately. So those were the cases we had of resistance, and there were very few that got actually infected just before they started PrEP. So I would also recommend to countries, for us initially, and what we probably call the missed opportunities, one that somebody would be tested, but then we give you like 2 weeks to allow for that window period, then you come back for another HIV test, and then now you'd be given PrEP. Then we realized that we were missing opportunities because people were not coming back. So we went back to just, you're tested, you're eligible, you get your PrEP, you move on. So we've had very few cases of drug resistance in the country. So probably also as countries, as we roll out PrEP, those would be some of the things that you also want to think about. How can you incorporate the resistance studies within your reference labs and have that done prior to putting people on PrEP. Neeraj, sorry, if you can just remind me, what was the first question?
The first question was what you've seen in terms of the impact of PrEP use on incidence and new infections.
So I'm not going to use any numbers to say to this percentage because we haven't done any impact studies. But what I can say is after the introduction of PrEP, we have equally experienced significant reduction in our new infections. So we may not attribute it entirely to PrEP, but I can say that with addition of PrEP into our prevention basket, right now in Kenya, I think we are talking about 22,000 new infections in the last country estimate study. So that for us is a reduction of more than 50,000 since we started in 2016 there. So I believe PrEP has contributed, only that now we haven't done any impact studies, so we can't use, we can't attribute specific percentages to that reduction.
Thank you, Patricia. And Jeff, welcome back. And I was just, no problem. I was just asking Patricia some of the questions that came through in the chat about what you're seeing, if you have any evidence so far of the impact of PrEP on the rate of new infections, and then also if you have any evidence on drug resistance from PrEP use.
Okay, so I'll speak on drug resistance. I don't have much information on the impact of PrEP. What we've seen is mainly through dreams, where we are seeing that there is an impact when you layer so many interventions on an adolescent girl and young women. So we've seen that in dreams, but at national level, I cannot say much about that. We haven't looked at that data, at least as far as I know. And in terms of drug resistance, what we have in country, in Zimbabwe, is we also have the GEM study. So we are fortunate to also be rolling out the GEM study, which is a resistance study on people who are on PrEP. And Pangaea also happens to be conducting that study at national level. So what happens is we are in touch with all the facilities that are delivering PrEP, and any seroconversion that's reported at the facility level is reported to Pangaea, and we take blood samples and they are taken for resistance testing. There haven't been that many seroconversions in relation to the number of people who've been initiated on PrEP. Currently, we have over 18,000 people who've been initiated on PrEP since 2016. And we have a small proportion of that number that have seroconverted, and we've managed to collect their samples. And the plan is when this, because GEMS is a USAID funded study. At the end of the study, ministry has a plan to then take over this as part of national surveillance. So it is important, and this was one of the questions that people were asking us during community dialogues, to say, won't I be resistant to art if I'm initiated on PrEP? What will happen to me? Is this part of the conspiracy theory that everyone should be on some sort of ARV medication? But the beauty of it is we've managed to address this in our communication strategy. And that's the plan we have in place for resistance testing for those who seroconvert whilst on PrEP. Thank you.
Thank you. Okay, one more set of questions that's around really how different populations are taking up and using PrEP and continuing on PrEP. So a number of the participants are curious to understand what you're seeing in terms of PrEP uptake and use, particularly among serodiscordant couples. And then also what you're seeing, I think, generally in terms of continuation of PrEP use.
So I think with so generally in Kenya, we are seeing better continuation amongst female sex workers compared to other populations. One of the challenges we had with the serodiscordant couples was when we had the U is equals to U, undetectable is equals to untransmittable. So people became a bit resistant and not wanting to start PrEP, because anyway, if somebody has reached viral suppression, then they cannot transmit the virus. But then now having the conversation that viral suppression is not static, based on different factors, it could be, you could move actually from suppression and get a higher viral load. So that conversation and support to serodiscordant couples is extremely important. And we've seen even some who had fell off from PrEP before, because when we started the national rollout, actually our phase for PrEP was serodiscordant couples. They were really targeted with it. So they started, and then at some point with the U is equals to U went down. But now with more information around viral suppression and the different things that could make someone's viral suppression move, then we've started seeing again serodiscordant couples coming back. So there's a lot of cycling in and out of PrEP among serodiscordant couples. But I think it's really critical that for serodiscordant couples, PrEP is a journey. It's not like a one-off thing that you give them and you just hope they'll continue using. It's a journey, and it means working with both the positive and the negative partner to continuously support them in making the decisions around cycling in and out of PrEP. But yes, female sex workers seem to give us better continuation than even MSMs and adolescent girls and young women. Adolescent girls and young women are really struggling. So equally, we are beginning to think as countries, as programs, what sort of support do we need to have in place for adolescent girls and young women, even as our new infections continue to be amongst adolescent girls and young women. So thinking differently, and among some of the things that we've been able to do also under options was to train HIV prevention ambassadors to support the adolescent girls and young women who are on PrEP and begin to have a normalized conversation around PrEP in communities and amongst the matriarchs that the adolescent girls and young women felt would be a better support for them. Yeah. Thanks.
Okay, so thanks, Patricia. So for Zimbabwe, what we were seeing through the reports coming through from the technical working group was that there was a sharp drop off at month 1 and month 2 for those who initiated on PrEP. And initially it was because people were hearing of PrEP for the first time, and they were just getting onto PrEP without giving it much thought, without understanding that they need to continue taking PrEP during their period of risk. So as long as they're at risk, they still need to continue on PrEP. But what we then saw after doing some longitudinal analysis of people who are on PrEP across implementing partners was that most people were, on average, people were staying on for about 4.5 months, and then they would stop taking PrEP. And the populations that stayed longer for PrEP are, like what Patricia just said, similar to Kenya, was the female sex workers, and also where there was support in serodiscordant couples, there's the HIV negative partner who's on PrEP stayed for much longer. So this is what we are seeing at national level. And also, what also came out was that people were hearing of PrEP once they get to the facility, but there was no information in the community around PrEP. So a person would just go to the facility, for example, for HIV testing, and then they hear there's this PrEP drug that people who are HIV negative are being given, who are at risk, and then they just take it. But what we also understood from our human-centered design work was that it doesn't take one person to make that decision. In most cases, it takes 2 or more family members or friends or peers to make that decision to initiate on PrEP. So this is when we then started talking about the communication strategy and what it is that needs to happen in the community in terms of educating the communities. But I think that's one of the biggest lessons we learned, that we should not just put PrEP in the facilities, even if PrEP is available. When people come, they might take it, but then continuation becomes a problem. We also need to address the community side, where we give them information and they understand what PrEP is, how does PrEP and PEP differ, how does PrEP and ACT differ for people to continue on PrEP, and also get the necessary support from the community we're coming from. Thank you.
Thank you, Daph. And just a note, there's a lot of good questions in the chat about methods or approaches to reaching specific populations like serodiscordant couples or adolescent girls and young women. Also questions about stigma and adherence. These are topics that we will cover in much more depth in future sessions. So we will touch upon them here, but we will certainly have more on those in upcoming sessions. One topic I did want to just ask about before we move on is there are several questions about financing for PrEP. Questions about, did you do a cost effectiveness analysis of a smaller, more focused rollout versus a general rollout? That was one question, is how did cost factor into those initial decisions? And then also a second question about the sustainability of PrEP delivery and how you're thinking about the financing for the future of PrEP beyond some of these initial projects. And then after that, we'll continue on.
All right, so in Kenya, we had a number of cost effectiveness studies that were conducted. And that's how we ended up making the decision on having a more general rollout than a targeted one. And it's because for us, the geographical areas that were really having high new infections and high HIV prevalence, they were general population as opposed to specific pockets of the population. So our decisions were made based on that. And so we had more of a generalized approach in terms of rolling out PrEP. And so around 2010, I think 2013, Kenya, our health system was devolved. So counties now are responsible for the health for delivery of health services to the populations within those counties. So one of the things that the National AIDS Control Council has done with the governors of the counties is to have a discussion on how to finance HIV prevention and treatment. So part of what counties do is to allocate a specific amount of money to HIV programs. We haven't reached there yet, like the percentages are quite small. And the percentage even for HIV prevention in Kenya is just about, I think, 2% of our HIV budget. But there's quite a lot of advocacy on domestic resource mobilization that's going on in the country. And also in terms of like the Global Fund mechanism, our country contributes to that. So that's part of what now the national government will tell us that part of their contribution now goes into the Global Fund, so a percentage of it comes back to give PrEP. But I wouldn't say we have really reached the point where we can confidently say that without donor funding, PrEP provision will continue. But I think we are making small steps towards that. And it's critical to have the right people engaging in this type of advocacy, people who understand costing, who understand the cost-benefit analysis, who understand how counties are financed, budget allocations, and then they're able to engage now with the specific counties to allocate probably higher percentages, especially where we are getting the new HIV infections. So this is work now for civil society, really to keep pushing and work together with government to help with that costing, and also ensure we follow through for accountability processes and ensure that whatever is allocated then is also made available at the point of implementation. So that's what I would say for sustainability. Thanks.
Thanks, Patricia. For Zimbabwe, we also have a generalized epidemic. It's not clustered in specific populations. And this epidemic then informed how scale-up was going to happen. And we were also aware of the eminent stigma that would come with rolling out PrEP to specific populations and excluding certain populations. So the decision to have to roll out PrEP to several populations at the same time, although in a phased approach, was really informed by the partners that were sitting around the table within the TWG. We had donors like USAID that had started delivering PrEP under DREAMS to adolescent girls and young women, and they strongly spoke against rolling out PrEP to certain populations and excluding certain populations, because the plan then for USAID, they hadn't started delivering PrEP among key populations, but the plan was already in place. And we also took that into cognizance. And we were also learning from what was happening in other countries that had gone before us. For example, South Africa started rolling out PrEP before Zimbabwe, and they were delivering PrEP in specific populations. For example, they started with female sex workers and then went to MSM, and we're sort of looking at Kenya as well, that also were before us, and they had they rolled out PrEP to the general population. And after doing like a SWOT analysis within the TWG, and also being informed by our specific epidemic, we thought going the general route was better for Zimbabwe and would have more impact in terms of averting HIV. And we also had started developing our implementation plan that was costed with various scenarios. And from that costing that happened, we realized that we'd get more gains by rolling it out to more generalized populations than sticking to specific populations. So that's what informed our generalized rollout of PrEP. Thank you.
Great. Thank you, Daph, and thank you everyone for the great questions. I know we have some more that we are certainly taking note of, and that we will come back to either in this conversation or in future webinars. But for now, we did want to move on because we have just a few slides prepared on the specifics of developing PrEP guidelines and developing PrEP implementation plans, because we know how relevant that is to a number of our panelists. And so I wonder if we could shift to those. And Aubrey, for the purposes of the slides, I might ask us to flip past the ones about stakeholders, because I think we really covered a lot of those in the conversation. And so maybe we could start with just getting a sense of what went into the PrEP guidelines in Kenya and Zimbabwe, and what are some of the decisions that you had to make in that process, and how did you make those decisions?
Thank you, Niraja. So for our guidelines, we decided to just have a chapter within the guidelines on the use of antiretroviral drugs for treatment and preventing HIV. So we had a chapter on PrEP, and the discussions at that time, one was eligibility, like who would qualify to take PrEP. So we were able to define the different risk categories, and also, like, in terms of the requirements, what do you actually need to, like, what tests should you have gone through before you're enrolled onto PrEP? So for us, the required test is HIV testing. So for the creatinine clearance, you need to do it within the first year of being enrolled into PrEP. So the clinicians would therefore then follow up with the different clients to ensure that those tests are done. So also, while working on the guidelines, we had thoughts around how would we train providers and ensure that they deliver PrEP in a quality, ensure that the services are of high quality. So also at that time, we had discussions on who are some of the medical staff who would be able to prescribe for PrEP, and also support with follow-up on those who are on PrEP. So we were able to categorize and have the clinical officers, doctors who would be able to prescribe PrEP. And also in terms of monitoring, like what would be required, how often should one come to the facility once they're on PrEP? So decisions on quarterly retesting were done at that particular time. And also the refills, for how long should you be given your drug? Should you come on a monthly basis, or should you also be given like a 3 months dose and then you come back after when you're coming for your testing? So all those decisions were included in the in the guidelines. And then of course now at the level of the technical working group, we came up with questions that were relevant for PrEP rollout. And these were either research questions that were yet to be answered, or generally all research questions that we could think of, and then started looking at which partners had already done something around this within the country or outside the country. Do we have some answers so that we don't have to redo a study? And then also discussed issues of financing for PrEP, both from a donor lens, but then also like at a country level, if we are thinking about sustainability. And that's what I alluded to before, that now that brought about a lot of advocacy on domestic resource mobilization. So part of the other things that were also part of the guideline were like, for us, PrEP was also available to pregnant women. They were not restricted. So I know these are major decisions that countries that are starting PrEP will be able to discuss at country level, and you can get evidence for all this, and that can support you in making decisions on who really is eligible for PrEP. Thanks.
Thank you, Patricia. And Aubrey, if maybe we could switch to the next slide, Def could take us through how Zimbabwe considered their guidelines.
Thank you, Niraja. So for Zimbabwe, I'll touch on 5 main issues that we looked at for in the clinical guidance. So we had to make decisions on who would deliver PrEP, and the guidance there was that because PrEP is an ARV, anyone delivering PrEP, any healthcare provider needed to have prior ART training. So for us, that was very clear because it's an ARV, so anyone who deliver PrEP has to be a healthcare provider who's already delivering ART and have been trained. And in terms of the frequency of visits, this was informed by the World Health Organization implementation guidance that had just come out. And we also followed the schedule that everyone should be tested every 3 months. Everyone on PrEP should be tested every 3 months. So for us in our clinical guidance, we had a section where they were required tests and then they were recommended tests. And the required test was that of HIV testing. And then creatinine, because we knew that not many facilities would afford creatinine testing. This would be a hindrance or a barrier to those who needed PrEP. So creatinine testing was a recommended test for those who were able to do it before being initiated on PrEP. But for those who are above the age of 50 and or have an underlying condition like diabetes, they were required to have a creatinine clearance before they were actually initiated on PrEP. So this was a clear requirement in the guidance. And also what we looked at was PrEP had to be delivered within a combination prevention framework. So it had to be delivered in combination with condoms, with lube, with services like voluntary null circumcision, STI management. And for serodiscordant couples, once the negative partner gets PrEP, it was also a requirement that the positive partner should also get ART. And we listed indications for PrEP. For example, we had STI history. Does the person have a history of STIs? Have they used post-exposure prophylaxis before? Did they have condomless sex? So those are some of the indications that that were listed in our clinical guidance. We also listed some contraindications. So like Kenya, for us, PrEP is not contraindicated in pregnancy. So that was not a barrier to a woman who were pregnant or breastfeeding. We also had contraindications like being positive, not knowing your status, or having a renal impairment. So we have those sections. And then the last section I'll talk about was that of clinical monitoring. So we have a section on clinical monitoring, what clinicians need to look out for when they're monitoring people on PrEP. So that's what I'll say on our clinical guidance, and it's available on PrEP Watch as well for those who want to take a look at it. Thank you.
Yeah, thank you, Daph. And we can share both the Kenya and Zimbabwe clinical guidance after this webinar with everyone, as well as links to the other tools and resources that were mentioned on the call. So just to keep us moving here, I want to just go to the next slides where Patricia and Daph, I would love you to just share a little bit more about what was in the implementation plans for PrEP across both Kenya and Zimbabwe. And I may ask us to do this a little bit quickly just because we're coming to the end of our time here. But I think an overview of what was included in the implementation plan would be helpful. And then we'll also share these implementation plans with the participants.
Thanks, Niraja. So I'll just walk quickly through this. For our implementation plan, which is also available online, we focused on leadership and governance, mostly targeting the Ministry of Health and the county leadership for buy-in and support. We covered service delivery, like how would this be done, the importance of considering different service delivery points, as opposed to just having PrEP at the comprehensive care clinics, but also thinking about diversifying where else PrEP would be offered within facilities. Commodity security, again, this looked at the commodity management information systems, quantification reporting, how would that happen? Communication, advocacy, and community engagement. Again, this largely was for the demand creation and continuous flow of correct information to communities and ensuring that the concerns of communities are addressed. Monitoring and evaluation focused on the tools. Also we had research and impact evaluations, financing and resource mobilization that's clearly stipulated in the implementation framework. In terms of major decisions, one for us was just breaking the stigma that PrEP is for a specific population of people who are promiscuous or perceived to have very high risk sexual behaviors, to anyone who feels they're at risk. And then priority counties for us, again, as I said before, was deciding on whether should we target specific counties and specific populations, but we went for the generalized approach, and then agreeing on the M&E indicators, especially having come from the demonstration studies, and everybody wanted their indicators to be included in the national M&E indicators. So there were quite a bit of trade-offs that happened at that time, and partners plus government agreeing on the key indicators that would actually tell us whether our rollout was successful. Thanks. Over to you, Dev.
Next slide, please.
Oh, Aubrey, could you switch to the next slide? Thank you.
Thank you, Aubrey. Thanks, Niraja. So I'll touch on 4 main issues, adding on to what Patricia has already said. So I've already talked about the decisions that were based on population and geography, so I will not belabor on that. And I've talked about the rollout scenarios and hotspot mapping. But
Oh, we may have lost Dev again. Okay. Let's see if she hops back on in a moment. I also just wanted to clarify, I think some of the questions were asking about studies across the 2 countries, and just to clarify that this is, oh yes, Dev, can you, yes, please go ahead.
Yeah, so I was saying for us, this process took a year, and I think it's important for countries to understand that it's not a process that can be done in a month. And for this year, it was a very consultative process. We had interviews with policymakers, technical partners, implementing partners. We had workshops, and this all came together in a draft implementation plan that was presented to the TWG, and a lot of things were questioned and changed. So I think it's important to highlight this process. So that's the first thing I wanted to say. The second thing was that we also looked at facility level assessments, and to help us do this, we through options, we developed what you called a facility readiness assessment tool that was looking at various components, including availability of complementary HIV services at the facility, looking at treatment services at the facility, looking at issues to do with human resources that will be able to deliver PrEP at those facilities. And we also looked at HIV testing volumes at the various facilities. And this was to try and estimate the number of people who would really take up PrEP in those facilities. So that too helped assess the readiness of a facility to deliver PrEP. If a facility was not ready, then certain things needed to happen before it started delivering PrEP. So that was outlined in our implementation plan. And also the third thing was that the implementation plan was also informed by, other than the interviews that I mentioned and workshops, the community dialogues that I talked about, to understand what communities knew about PrEP, what is it that they would want to hear about PrEP. And we had also conducted a knowledge, attitudes, and practices survey among healthcare providers to try and understand what the knowledge levels for the healthcare providers were to inform training needs, and also what the attitudes were, what the practices were, what needed to be changed before PrEP delivery would take place. And we also took into account the implementation experiences from clinical trials, and then the demonstration projects that happened in country. And lastly, what I wanted to mention was that our implementation plan was also costed at the end of the day, and this costing will help countries understand what level of resources they need to fund this implementation plan. Is this something that they can use using domestic resources? Do they need external funding, or can Global Fund or USAID, depending on who the major donors are in the country, and where to get that money from to be able to fully implement your implementation plan? So for Zimbabwe, these were the major issues that we considered, and you'll see the picture there is the picture of our implementation plan, and you'll be able to locate it online. Thank you.
Great, thank you both. And one final question that we would love to end on, it's just, and I think we just have a few moments here, is, you know, what advice would you have for other countries in terms of what really worked for you, and what didn't work, and what was challenging? And I think we also want to keep in mind kind of how this could work at different resource levels, and particularly for countries who maybe don't have that many resources to dedicate towards initial PrEP rollout. What would you recommend?
Yeah, thank you.
And I think we have about 3 minutes each.
Okay, thank you very much. And probably just also to talk about resources, there's quite a bit that has already been done by countries and different projects. There are tools that are available and can freely be adapted to country context so that it's less expensive, especially in terms of planning. And then just to quickly get to the points that I think are really success factors, one is political goodwill. And this really is ensuring that the Ministry of Health is on board with the rollout of PrEP, and they're willing to support. They can then invest, especially in terms of training providers. And then availability of funds. This will really give you directions in terms of making decisions on the scope and coverage. Community engagement, so ensuring that communities have a clear understanding of what addition PrEP is bringing on board, and who PrEP is for, and how they, the communities can be able to benefit from the rollout. Ensuring you do a stakeholder mapping and engage the different stakeholders. Oftentimes we end up either just engaging government and a few civil society organizations that are really large, and we forget the basic communities where a lot of the mobilization and follow-up happens, and that's where we have all sorts of myths and misconceptions. So engaging at that particular level is extremely important. And then having a functional technical working group. What I would tell you is, from our experience, the first 6 months of planning, you have so many meetings, frequent meetings that sometimes make us work late into the night, but it's worth it. And after that is done, then you can, have your normal quarterly forums. But we really need to make sure that from the word go, we get it right with our planning. Thanks.
Great. Thank you, Patricia. And Aubrey, if you could maybe skip the next slide, which we will include in the presentation, but for purposes of time, we'll just go to the next one. So Jeff, would also love your 2 minutes of advice for the participants.
Thank you, Niraja. And in brief, I would say, firstly, political willpower is important because Ministry of Health and Childcare is the one that drives this whole agenda. Without their input, nothing will happen. And secondly, what we found really important was the dissemination of guidelines. Having guidelines crafted is one thing, but making sure they get to the facilities and then the healthcare providers understand the guidelines, they understand the standard operating procedures and job aids. That is really critical because in some cases we found that the PrEP commodities were there, but healthcare providers were not familiar with the guidelines and were not delivering PrEP at those facilities. And standardizing, thirdly, standardizing the provider training materials was important for us to make sure across the country providers are getting the same kind of training, they're getting the same information, and there's no misinformation across facilities. When a person goes to one facility and the next they get the same information. And also, fourthly, it's the communication strategy. For us, the communication strategy was really important to generate demand for PrEP services. And also, fifthly, financial resources. It's important to get the key stakeholders around the table so that they give input and also they indicate where they're able to fund and what they are unable to fund. Clinical mentorship was really critical because just getting the guidelines and understanding what they say was different from actual practice. So at national level, we have a team of clinical mentors that go around facilities trying to understand the challenges that healthcare providers are facing, and they work together to try and resolve those challenges. So that was really important. And in terms of challenges, sustaining demand creation was really a challenge for us because we are unable to go full scale on having like PrEP awareness campaigns across the country simply because of resource constraints. We are unable to deliver PrEP in all facilities. So we had to do it in within pockets of districts and facilities. And this became challenging to get everyone to understand what PrEP was. And also PrEP quantification, we found that the quantification process needed to happen more frequently than what people had anticipated in the beginning, because at times we'd get stock out of PrEP, at times there will be demand and the PrEP commodity is not available, or people know about PrEP, they're asking about PrEP, and then the healthcare providers not know what to say to people. So the quantification is important, especially in the first year, so that you get the trend, and then maybe after that you can do it biannually. And I think lastly, I mentioned the communication strategy, which was important to get information to the communities. And lastly, I will mention training as many providers as you can per facility. We ran into a challenge where we trained a couple of providers at per facility. And what would happen was that if those providers were not available or were away on leave, no one was there to deliver PrEP. So making sure you train as many providers as possible per facility goes a long way in making sure there's continuation in service provision and there's no service interruption. So thank you.
Great, thanks, Steph. And thank you both so much. I'm going to pass it over to Katie to just take one minute here to wrap us up and preview what we have coming up next. Thank you both.
Well, thank you so much, Patricia and Daph, for that, for your presentations. That was really, really great. So very quickly, because I know we're coming to time here, our next session is going to be on developing PrEP guidelines. I did, and that's going to be on August 19th, and that will kind of get into the details of what is in the PrEP guidelines and details around some of those those topics in terms of eligibility requirements, screening, risk assessments, laboratory monitoring. So it's a great place to answer some of the questions that we've seen on the chat here today. Oops, my screen just went away. And I would quickly like to ask, by show of hands, if everybody has their hand button ready, if you think some sort of PrEP basic session might be helpful in terms of talking about PrEP effectiveness, the clinical trial research, basics around the lab monitoring and that sort of thing, if that would be helpful to have, or if you think that that is not needed. If you think it's helpful, I'd love to just see your hands coming up just while I talk, and then I can kind of get a sense of whether that's something to add. Following this, we are going to do a poll at the very end, so please stay on because we really want to know what sessions you think will be helpful for the next few sessions, and what type of topics will be nice to cover. So we are anticipating PrEP guidelines and diving deep into those on August 19th, and then on September 16th, something similar with the development of PrEP implementation plans. What's in those plans, key decisions that countries have needed to grapple with in developing those plans, and what they've looked like. So that's kind of our calendar for the next couple of months. And as always, we really welcome your feedback on that email that I provided earlier in the presentation. And the link to register for these upcoming sessions is at the bottom of the screen today. Okay, I think next slide. And as I mentioned, there's the PrEP Watch page. I think we can, that was mentioned earlier, you can register on that page directly for the upcoming webinars, and the recorded session from today, as well as the slide deck, will be available on PrEP Watch as well, and we will let you know when that's posted. Okay, so time for the exit poll, and that will pop up on everybody's screen. And thank you so much, everyone, for attending, and we hope to see you again in August. Thanks. I see some people are also putting topic ideas for future sessions in the chat. If there are topics that are not listed that you'd like to see, please do put them in the chat. That would be very helpful.
Katie, I'll keep the poll going for about 30 more seconds.
Great, thanks, Aubrey.